Okay, guys, I'm going to go right into heart failure, or the failing heart, which is threats to oxygenation part 3, or 3B. It's complications of an MI, heart failure, pericarditis. I, again, give you this disclaimer. I have been preparing these things while I'm preparing my home and for the hurricane. And of course, we're all under a lot of stress, and just give you this disclaimer that if I say something wrong or list something twice or forget something, just remember it's really important to read your book and read the chapters that are covered, that are in your module, the page numbers and everything. There's only one lecture left after this one, and that one's your hemodynamic monitoring circulatory devices. Mrs. Schneider said that if we still don't go to school on Tuesday, which it's looking like we probably won't, then she may put a lecture of video, I think an audio lecture, in everyone's course for that. So keep that in mind. Be on the lookout for that, and that's if we have power and if you can get to it. Again, read. Save your book from the flood, and try to read what you can. Work on your module, on your assignments. Be proactive during this time, but also take care of your family. That is the first priority, and yourself. So I'm going to go right into this. Again, I'm going to go faster. Again, if you need to, you can pause it. You can go back. I would still write these things, even though you have everything in front of you. Time and time again, research has shown that if you write things down, then they are better absorbed into your brain. So that is the whole purpose in doing lectures this way, is to actually help you all, but to have you write it so that it's one extra way to get you the information to your brain and help you retain it. So just keep that in mind as we go. Complications of myocardial infarction are dysrhythmias. So we're talking about myocardial infarction and things that happen after an infarct. So a lot of times you're going to get dysrhythmias, which are the most common complication, and these often can be as a result of electrolyte imbalance or CNS stimulants. Another complication is sudden cardiac death, which we talked about that, right? Another complication would be acute pericarditis or Dressler syndrome, and we're going to talk more about that because that is one of your learning objectives. Heart failure, which we're going to talk a lot more about that, and cardiogenic shock. So as far as sudden cardiac death goes, in order to prevent that, sometimes they will have a patient wear a Holter monitor for 24 hours, which is just a monitor to monitor the heart. They'll do an exercise stress test to see exactly, if they're having problems when they, are active. They're having changes in their EKG or ECG. And they'll sometimes put in an implantable cardiac defibrillator or an ICD, which will shock the heart. Remember, we talked about that. And then a lot of times they'll give antidysrhythmic drugs. A lot of times amiodarone is used in conjunction with an ICD to decrease episodes of ventricular dysrhythmias. There's a whole table on page 801 of your antidysrhythmic drugs. It's 36-9 table. What are some complications of myocardial infarction, like we were talking about? Acute pericarditis. And the acute pericarditis occurs within the first 48 to 72 hours after an MI. And acute, you think acute, a little more serious, right? And what is it? It's inflammation of the visceral or parietal pericardium. Can't talk. So it's inflammation, basically, right? Clinical manifestations, of course, you're going to have chest pain. And the chest pain is eased by sitting up and leaning forward. So that is your telltale sign that it could be pericarditis, right? Is if they sit forward, lean forward. They can have a pericardial friction rub. And I'm sure you all, if you haven't heard those on our sounders or on one of the mannequins, it just, it sounds like a rub. You can hear abnormal sound in the heart when you listen to the heart. ECG changes. Remember we talked about, you may see diffuse ST segment elevations, and then treatments often anti-inflammatory drugs, corticosteroids, NSAIDs, and then a pericardiocentesis, or some people you may hear it called a cardiocentesis. But that is when there's a good actual visual of it in your book, but they actually take a needle and draw that fluid off. This is just a good picture. It shows you the pericardium of the heart. Remember I talked to you about that on day 1 of these lectures, where the pericardium is kind of like a sac that the heart sits in. And there's just about 10 millimeters of fluid in there. And if that fluid gets infected or that area gets inflamed, then that's when you're going to see the problems. But please note, there are also pericarditis can occur from any inflammation or infection. It's not just after MI. So if you want to review this, on page 814 through 817 in the Lewis book would be a good place to just look over it, and there's a good chart there that talks about the different things that can actually cause pericarditis. But you can actually pull the word apart and see pericarditis. Itis means infection, and then Dressler syndrome, which is pericarditis with effusion and fever. And it's usually 4 to 6 weeks after an MI. And you're going to have chest pain. You're going to see chest pain, a pericardial friction rub, pericardial effusion, and arthralgia. Treatment for this is short-term corticosteroids. Another complication of after an MI is heart failure. We know this, right? And we're going to talk more about it. But heart failure is basically decrease in pump power. And then you've got your cardiogenic shock, which is also a complication of myocardial infarction. And that is a pump problem. We're going to talk more about cardiogenic shock in test 3 information, test 3 lecture material. But cardiogenic shock is definitely a complication of MI. And this occurs usually because of severe left ventricle failure. Your left ventricle is your biggest, strongest pump of the heart. And if it fails, then your heart, can be in shock and go into cardiogenic shock, and then you've got a pump problem. This we'll talk more about too in the hemodynamic monitoring, because your balloon pump is often what they'll put there. They'll put that balloon pump in to help that left ventricle. All right, we're going to talk about heart failure, and this is a review for you all. I felt like it was a good review, and I may go into in depth, so you can just fast forward it if you know what I'm talking about, if you feel good about your heart failure information. But I wanted to just give you a good review and also go over what I felt like was important as we're talking about the heart. So heart failure is an abnormal clinical syndrome involving inadequate pumping or filling of the heart. It results in the heart's inability to provide sufficient blood to meet the oxygen demands. And this can be acute or chronic. Heart failure is often associated with long-standing hypertension, CAD, and myocardial infarction. The incidence increases with age, of course. Like I talked about, as you get older, things don't work as well. Things wear out, and the heart is one of those things. Often you'll see an ejection fraction of less than 35%. And it can be abrupt or subtle. Like I said, it can be acute or it can be coming on very slowly. And a lot of times your compensatory, we're going to talk more about compensatory mechanisms, but your compensatory mechanisms are mobilized to maintain, I didn't finish this, adequate cardiac output. So with heart failure, your body is going to do its best to compensate, right? So that it can have adequate cardiac output. And we're going to talk about how it does that. So what happens, your body releases epi and norepi, right? Your sympathetic nervous system is activated. So you're going to see an increase in heart rate. You're going to see an increase in myocardial contractility. Anytime the body's sympathetic nervous system is activated, you're going to see these things. A peripheral vasoconstriction, right? It vasoconstricts to shunt all the blood to the important organs. Initially, this helps, but then it becomes harmful. Because what happens, over time, a systematic inflammatory response occurs. You're going to have neurohormonal response. And this response is going to lead to elevated levels of norepinephrine and angiotensin II The kidneys are going to release renin. And we just had a power surge, so if you're hearing something in the background, there was a power surge, even though it's not even raining outside. Your kidneys are going to release renin, and your RAS system is activated. Your posterior pituitary is going to secrete ADH. And the ADH, when this ADH is secreted, the endothelium and the pro-inflammatory cytokines will often cause some over time, it will cause some myopathy, the skeletal muscle myopathy. And what happens with that, with this process, it leads to ventricular remodeling of the myocyte cells. So this is like a neural hormonal response. So basically, as your cardiac output falls, your blood flow to the kidneys decrease. This is sensed by the kidneys, and in response, the kidneys release renin, which converts angiotensinogen to angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by converting the enzyme made in the lungs. And then angiotensin 2 causes the adrenal cortex to release aldosterone, which results in sodium and water retention. And then an even more increase in peripheral vasoconstriction, which increases the blood pressure. This is your RAS system. And then because the low cardiac output causes a decrease in cerebral perfusion pressure, the posterior pituitary gland secretes the antidiuretic hormone, or ADH, which is also called vasopressin. And then ADH increases water reabsorption in the kidneys, causing water retention. And as a result, your blood volume is increased in a person who's already volume overloaded. So this is a major factor in this development of heart failure. So here you go. You've got your dilated heart chambers. Dilation is enlargement of the chambers, right? And I've drawn it out there. See how they look bigger? They're enlarged. Just think about a rubber band. And when it's stretched over and over and over again, it loses its ability to stretch. And then it's kind of just stretched. Like, I don't know, a lot of girls may be able to relate to this, but you know, your hair ties. The more you use them, then you've got this once smaller hair tie or hair rubber band, a hair band that's bigger because it's stretched and it's lost its elasticity. Or you can think about it. You can think about it any way you want to think about it. When your elastic loses its elasticity, and then it's just kind of stretched out. So it loses its ability to stretch. This is the dilation, and then that leads to decreased cardiac output. So it is a compensatory mechanism, and eventually it leads to inadequate output because of the overstretching. And then another concept or another compensatory mechanism is your hypertrophy heart chambers. You got an increase in muscle mass. See how big that muscle is? And over time, it leads to poor contractility due to decreased cardiac output and decreased cardiac output. You've got a thickened heart muscle. So what happens with more muscle? It requires more oxygen to perform the work. So over time, your hypertrophic heart muscle has poor contractility, requires more oxygen to perform work, has poor coronary artery circulation, and the tissue becomes more easily ischemic. And there you go, you're more prone to dysrhythmias. So I got you a good contrast here of the two different types. You've got your enlarged ventricles. On your left, you got your dilated heart. And then on the right, you got your hypertrophied heart, which is the thickened heart muscle. So, because during all this time and while this is happening, you've also got some counter-regulatory mechanisms going on. And this is the body's ability to maintain balance. And it does this by producing natriuretic peptides. And that is where the BMP comes in. So these peptides are released in response to an increased blood volume in the heart. Causes diuresis and a lower blood pressure. And this counteracts the SNS and the RAS effects. So now we're going to talk a little bit about left-sided heart failure, a left-sided heart failure. It's the most common because of left ventricular dysfunction. You get blood backing up into the left atrium and the pulmonary veins. Think about the left ventricle. Think about it not being able to pump effectively or pump well. You're going to see, because of that backup, you're going to see pulmonary congestion. What is congestion? Wetness, right? And edema. What is pulmonary edema? What is it? It is the left ventricular dysfunction that causes blood to back up into the left atrium and the pulmonary veins, like we just talked about. What are you going to see? You're going to see anxiousness, restlessness, agitation, tachycardia, increased blood pressure. Let's just say whenever you see someone that is having trouble breathing or having chest pain, you're going to see agitation. You're going to see fast respirations, right? Most of the time, sometimes greater than 30. They're breathing fast. And you're going to see an increase in blood pressure. But decreased O2 levels. So, of course, your vitals are important, your blood pressure is important, but you want to see what their O2 level is. You want to do that pulse ox on these patients. You want to see if they are able to perfuse, if their oxygen levels are low, and what kind of intervention needs to be done. You're going to see orthopnea. You can see pink frothy sputum, wheezes, diaphoresis, pale, cyanotic. These are sick people if they've got some pulmonary edema going on. And there's different levels. It could be mild, it could be more acute. Treatment is diuretics, morphine, nitrates, oxygen, and positive inotropes. Let's talk a little bit about the morphine. We talked about this when we talked about Mona and heart attack. Morphine, not only does it relieve pain, but it also helps relieve anxiety. Which will assist in improving cardiac output. Not a whole lot for these people, but a little bit. Positive inotropes. A lot of times you'll see low dose dopamine, dobutamine, bronchodilators. And then now we're going to talk a little bit about right-sided heart failure. We've already talked a good bit about it in the other lecture. But the primary cause of right-sided heart failure is left-sided heart failure. That's the primary cause. We talked about some other things like they can cause right-sided heart failure, the cor pulmonale, lung disease, but this is right-sided heart failure due to left-sided heart failure. Other causes of right failure, like we talked about, right ventricular infarction, PE, cor pulmonale. And let's talk a little bit about acute decompensated heart failure. What is it? It's an increase in pulmonary venous pressure caused by left ventricular failure. And acute, what does acute mean? Acute just means it happens acutely. The heart's no longer compensating, or the compensating efforts are no longer sustaining. Think about it as like an exacerbation. So you're going to see with this, you're going to see pulmonary edema. They're going to be anxious, pale, short of breath, orthopnea, respiratories greater than 30, or respirations greater than 30. You're going to treat them by putting them in high Fowlers. Like I said before, you're going to want to do a pulse ox on these people. You're going to want to see what their oxygen level is. They may get BiPAP. You may even see them put in a balloon pump. Of course, they'll be in ICU. In this case, if they need a balloon pump, I think I spelled balloon wrong. They're going to be intubated. Their vital signs and urine output is going to be Q 1 hour. These are sick people. They're going to be on telemetry, hemodynamic monitoring. And when I say hemodynamic monitoring, like an ART line, an intra-arterial line, again, we're going to talk about that. We talk about hemodynamic monitoring, but these are your sick people that are going to be in ICU, going to be monitored closely. There's a meds table. It's table 35-7 that talks about some treatment, diuretics, positive inotropes like dobutamine. Let's just contrast left versus right. Again, I know I'm just doing a lot of repeat here, but I think it gets confusing for some people, so I like to do a contrast. So with your left-sided, blood backs up through the left ventricle, then the pulmonary veins. You've got crackles, pulmonary edema, S3, S4, changes in mental status, restlessness, anxiety. That with both, I'm sure. And then the right-sided heart failure, you're going to see backward flow to the right ventricle and the system circulation. So your whole system circulation. Cool cyanotic legs, You're going to have jugular vein distension. Ascites, hepatomegaly. So right-sided, you got your whole system circulation. You're going to see edema. So that is your right and left-sided. Just a little synopsis of the difference. So if you're wanting to really just burn it in your mind, think about right-sided heart failure, JVD, ascites, hepatomegaly. Okay? Left-sided heart failure, pulmonary edema, S3, S4, crackles. All right, so we're going to go right along. What are your clinical manifestations of chronic heart failure? And I do believe y'all talked a lot about chronic heart failure in level 2. You might have talked about all this. This is from chapter 35. All this heart failure. There's a whole chapter on it. It is in your reading to read the whole chapter. But again, it may be a review for you. But I would suggest going through your module and your chapter and your objectives. The chronic heart failure is your assessment is your fatigue, dyspnea, paroxysmal nocturnal dyspnea, which is short of breath when you're laying flat at night and you're nocturnal sleeping. Edema or weight changes. A lot of times it can be sudden, or it can be, if it's sudden, which is greater than 3 pounds in 2 days, it can be acute, right? It can be acute decompensated. But a lot of times, especially chronic, these people weigh themselves daily and they can have some fluctuations. And that's why weigh-in is such an important thing with your patient, heart failure patients, is to monitor this before it gets to this acute stage, right? That's what we do in healthcare. We want to keep people from getting very sick. Prevention is always the key. You're going to have behavioral changes and neurologic changes. Again, lack of oxygen, right? Cerebral circulation could be reduced because of decreased cardiac output. The heart's just not able to perfuse, to get blood as fast, as quick as it needs to the cerebral circulation. The patient or caregiver may report unusual behavior, including restlessness, confusion, decreased attention, memory, or even memory. And this is just a secondary to poor gas exchange, like I said. It's often seen in the late stages, though, of heart failure. Anxiety, like I said. Crackles, S3, S4. This is all chronic. What are your diagnostics? A lot of times you're going to see, you're going to be monitoring the potassium and sodium levels, the BUN and creatinine, your LFTs, or your liver function tests. That's what LFTs are. You're going to have an increased BNP, like we talked about, right? We just talked about that. When that BNP is elevated, it's indicative. And a lot of times I know you all want numbers. There's several different numbers out there. I've had doctors say if it's greater than 700, if it's greater than 1,000, I worry. Just know that when it's elevated. Chest x-ray, an echocardiogram, they want to see how that heart is working. That echocardiogram can also tell them the ejection fraction. how well the heart's putting out the volume. Drug therapy. Diuretics. They're used to reduce edema, pulmonary venous pressure, and preload. Diuretics are very effective in relieving the congestive symptoms of heart failure. ACE inhibitors. ACE inhibitors are the primary drug of choice for blocking the RAS system in heart failure patients with systolic failure. ARBs. A lot of times they'll give these to patients who cannot tolerate ACE inhibitors. Why would they not be able to tolerate ACE inhibitors if they get the chronic cough, angioedema, right? Aldosterone antagonists, like your spironolactone, your aldactone. And these block harmful neurohormonal effects, like we talked about, of the aldosterone on the heart and blood vessels. And they're also potassium-sparing diuretics. Beta blockers. They block the negative effects of SNS, the sympathetic nervous system. They can also help in reducing the effects of renin. Beta blockers reduce myocardial contractility, so they have to kind of be started slowly for the heart failure. Nitrates, of course, they cause vasodilation. Positive inotropes. You've got your DIG, or your lanoxin, which increases the force of cardiac contraction. So they not only have an inotropic action, but they also decrease heart rate, which is a chronotropic action. So inotrope, think force, think contractility. Chronotropic, think time. So they do both. They increase the force of contraction, and then they also decrease heart rate. This action allows for more complete emptying of the ventricles. Although patients taking DIG are risk for DIG toxicity, hypokalemia, and hypokalemia can be secondary to the use of potassium depleting diuretics such as thiazides or loop diuretics. These are a lot of times a common cause of DIG toxicity, taking the diuretics, but they need the diuretics. Low serum potassium enhances the action of DIG, causing a therapeutic dose to reach toxic levels. And then similar to this, hyperkalemia inhibits the action of DIG, resulting in a subtherapeutic dose, meaning it's not therapeutic enough. And both hyper and hypokalemia can cause dysrhythmias. So you have to monitor your serum potassium levels when someone's taking digoxin. Nutritional therapy, which is very important for heart failure. They're going to be on fluid restrictions. A lot of times they can do ice chips, hard candy, gum for this. Sometimes for severe heart failure and renal insufficiency, fluids may be limited to 2 liters per day. So there are some things they can do for that. A written diet plan is often important. This is just so patients can actually see it and just have something visual. I spelled that. This should say examine labels. Instead of examine labels. This is for meds. A lot of the meds that contain like pseudoephedrine, anything, it's even sodium. So they have to examine labels, especially like over-the-counter drugs, even like laxative, cough medicines, and then also food labels. There's so many things that have such high sodium. I mean, you've got your canned foods, of course, even some frozen foods, especially the frozen meals. They have to really look and like meats, like deli meats, those are high in sodium. So they have to examine labels, weigh themselves. Sometimes eat smaller, more frequent meals again, just because of the body's need, the lack of oxygen, need for more oxygen. It takes a lot of energy sometimes, like I said, just to chew and to metabolize the food, digest it. So small, more frequent meals. Planning, implementation, and intervention for chronic heart failure. So your goals are to decrease symptoms, decrease edema, of course, decrease hospitalizations. And to do this, you're going to want your patient to be compliant with a regimen and even increase exercise tolerance. Like I said, cardiac rehab is often under prescribed for these people, but they can benefit greatly for just getting stronger. They're not going to go do a mile or an hour on the treadmill, but if they can just get stronger, I take that back, they may can do a mile. It just depends on their level of chronic heart failure. But the goal is compliance, is following this regimen. No complications. That's a goal. You're related to heart failure. Like I said, they don't want them to have to be hospitalized every week because they're not weighing themselves or they're not following their diet. It's very important to be compliant. People are just living longer, so their heart, you're going to see more and more of this. So how do we implement this? Health promotion, right? Like I said, cardiac rehab, getting them on board for this through, their willingness to comply. Assess their compliance, assess their attitude, assess how they feel about it, their beliefs. Teach them, a lot of teaching is involved here. Education, flu and pneumonia vaccines are very much recommended to prevent flu, and pneumonia for these patients. Interventions, again, restrict salt, sodium, conserve energy. Oops, went too fast. Decrease anxiety, pacing of ADLs, like I said, do things in small amounts, they may have to, take time to do their morning routine, and take rest periods. And most important, they need to evaluate, and as healthcare, we need to evaluate and establish supportive relationships with their family, but not only with their family, with us. Trust is a major thing in this. If they trust you, they're going to listen to you. So that's why it's so important, why we teach y'all about therapeutic communication, so that the client will trust you. Because it's proven, I did some research on this when I was doing my master's degree, it's a proven fact that if the patient trusts you, they will be more compliant with their regimen. Again, teach, right? Teach the patient caregiver physiologic changes that have occurred. What's happened to the heart. The heart, is not working as well. So you got to teach them and the adaptation that needs to occur. Not only physiologic, but psychologic. You may have to, sometimes people have to change their way of thinking. Integrate patient and caregiver into the plan. You're going to teach low sodium diet, daily weights, med compliance, signs and symptoms of toxicities like I was talking about, and the importance of activity and rest, heart rate and blood pressure monitoring, signs and symptoms of hyperkalemia, because like I said, the DIG and the diuretics can affect this. What are some nursing diagnoses? Y'all probably, if you did your case studies, I believe one was about heart failure, so you should know these, right? You can just skip right through this. But your nursing diagnosis is your impaired gas exchange, right? This can be related to increased preload, alveolar capillary membrane changes, decreased cardiac output, and this is often related to altered contractility, altered preload, or altered stroke volume. Excess volume related to increased venous pressure and decreased renal perfusion, secondary to cardiac failure because of that RAS system, right? Activity intolerance related to imbalance between oxygen supply and demand. Okay, and then complications. This is again a review. Pleural effusion, dysrhythmias, left ventricular thrombus, hepatomegaly, renal failure. We've already talked about all of this, but these are some complications. These may be why you see patients back in the hospital. So what's wrong with this heart? I did this so that you can see the different hearts. The first one is a normal heart. The second one is, if I was in class, I'd be asking all these questions. But the second one is a dilated heart. See the dilated chambers? And then your third one is your hypertrophic cardiomyopathy. So you've got all that extra muscle there. And that is all. This took me a little longer than I wanted it to. And I did try to go through each stop with you. I don't know if it'll show because I'm doing it this way. I'm just recording it. I'm not doing it on a projector. It may show you all these stops, and I apologize for that. But I felt like it might be better if I did it that way for you for this lecture. And stay safe, and I hope to see you all next week. And I'm going to post these for you all. And that concludes these lectures.